All right, folks, I think we're back. Is the mic working? Can you hear me? Okay. All right, everyone, thanks for coming back on time. We have our next half of our panel ready to go. Just one note, and I think I did mention this before, but I'll just remind folks, there is a Q&A session after this. So if you can hold your questions as you have already, we appreciate it, but we didn't want you to think we would just be talking the whole time. There is a Q&A coming up. So thank you so much. And with that, why don't we go ahead and get started and bring our panel up. Thank you, David.
Thank you. Good morning, everybody. It's really a great pleasure to be here. Before I start talking about direct trust, I want to point out something that will perhaps be one of the takeaways today, is that one of the things you're seeing is how much work is already being done in the industry on trust frameworks and security and trust frameworks from different kinds of organizations. And I think by the time that this panel gets through, you're going to have even a better sense of the aggregate industry experience and collaboration that's occurring. So I think everybody probably knows that direct trust is an outgrowth of the Direct Project, which was started in 2010 and delivered the Direct Project standard, the direct standard for exchange of health information. Direct Trust was the organization that was then started in 2012 to provide the security and trust framework around the exchange of health information via the direct standard. The basic idea for the direct standard is fairly simple. That is you want to be able to move data from one user of an electronic health record or a personal health record in the case of a patient to somebody that you know has an endpoint address somewhere in the nation, somewhere on a network, using the internet as the basic network. And then the issue becomes, well, how do we know that we can trust those parties when they're exchanging that information? Because that incoming message or the outbound message is going over the internet and it's likely to contain protected health information. So Direct Trust was started as an outgrowth. It was actually a work group within the Direct Project to solve that problem of how do you scale trust? How do you make it possible for entities that need to be mindful of security and trust problems and associated breaches of information to trust one another when millions of transactions are being transacted? As many of the people here who are, like Jitin said, Direct Trust is a very young organization, and the amount of information has been doubled almost every year for the last 3 years. So just to give you an idea of the extent of the Direct Trust network, we now have 40 health information service providers who are members of Direct Trust. We are a nonprofit organization, a trade alliance. They are contracted with 400 or more electronic health records and personal health record, health IT systems that are certified by ONC as being able to participate in the meaningful use programs. The network now touches, it reaches 100,000 healthcare organizations, and there are 1.5 million direct exchange endpoints known as direct addresses. Direct exchange is used by electronic health record users, of course, but it's also used a lot by health information exchanges. So it's not limited to electronic health records or personal health records. It's also used by applications used by health information exchange. We have 2 federal agencies. The Veterans Administration, for example, has its own HISP. We are now up to about the last quarter. We just got our data, and there were 40 million transactions via direct in the second quarter of 2017. And we're on target for approximately 140 million, perhaps as many as 200 million, maybe 175, something like that for the total year of 2017. So this is a network that is moving a tremendous amount of health information, mostly for the purposes of transitions of care and care coordination, but there are other use cases replacing the fax in a lot of places that are coming on board. Oops. So let me see if I can get the right, there we go. This is not all of the direct addresses in the country. We have a directory of about 600,000 direct addresses, and what we've done here is map them in groups to show you sort of the national exposure, the national extent to which this distribution system works. So what is the trust framework composed of? Well, first of all, I want to say it's a very dynamic situation. This is not something you build and then forget. There's ongoing technical, human system, legal policy, and infrastructural components, as well as the governance component that is necessary to maintain the integrity of the trust framework and its participants, such that they're not cheating or breaking the rules or forgetting to be accredited and so forth. The primary purpose of having this trust framework in the direct trust world is to assure that people can be confident that everybody who's participating in it is abiding by the roles and the practices that they agree to abide by being part of the network. It's a very high-level assurance network in the sense that the parties who are in it have to be identity-proofed at what we are now using as NIST level 3, which is a fairly high level of identity assurance. And that allows it to scale trust. So hospital A moving data to hospital B doesn't have to engage in negotiations about, well, what kind of security operations do you engage in? How can we know that the information that you're sending us is coming from who you say you are? How do we know that the digital certificates that are used are actually not revoked, or that the assertions they make about identity and about security are actually true? And at the heart of the direct trust framework is another trust framework known as a public key infrastructure. And I want to spend a little time talking about that because it's a very important part of what has been built by the direct trust community. First of all, let me just say that these 4 concentric circles indicate the legal agreement policies, the accreditation programs, the net directory services, and our network infrastructure, which includes 2 trust anchor bundles, and then that governance and compliance oversight role that we play. We have had occasionally to remove a party from the trust anchor bundle, for example, for a failure to comply with the policies and practices involved. So, a public key infrastructure is defined the way you see it here. It's a set of rules, policies, standards, and procedures needed to create, manage, distribute, use, store, and revoke digital certificates, and to manage the public key encryption. A very important part of this is the private key that's involved in public key infrastructures. No one should ever get your private key. The public key is, of course, made public in order to engage in the encryption and signing and other aspects of a public key infrastructure that are made possible by a public key infrastructure. A core issue here, and one of the reasons why we had to develop a public key infrastructure as part of our trust framework, was this issue of identity proofing. All 1.5 million of those individuals and organizations that you see as addresses or endpoints in the direct trust network have been identity proofed at a very high level of identity assurance, either NIST level 3 or FBCA medium. And that means that in general, someone has had to actually look at a government ID and verify that ID along with other additional information in order to make sure that the person in cyberspace is who he or she actually says they are on a reliable basis. And a recurrent basis. You don't just identity proof once. Identity that is conferred or asserted by a digital certificate, it can be verified by the issuing entity, the third party, like the certificate authority or registration authority, often called identity providers, in real time. So this is a very, very strong way. It's consistent with what the federal government uses for its practices and procedures regarding what is known as the FBCA cross-certification and the certificate authority used by different federal agencies to trust one another. In the direct exchange world, 1.5. In the direct trust world, the primary use of the certificates themselves are for encryption and decryption of the messages going to and from the sender and receiver, and for verification of the messages, that is, signing of the messages and attachments. So, last slide. This is a summary of the components of the Direct Trust framework. I won't read these off to you, but you can see that they have legal, policy, technical, standard basis accreditation component, and then perhaps most importantly, the public key infrastructure that deals with the assurance of identity and the security operations of the parties that are delivering the services. Thank you very much.
All right. Well, good morning. I'm Mary Ann Yeager. I'm CEO of the Sequoia Project. We are a nonprofit C3, really with the unique mission of advancing interoperability. We are a steward to the eHealth Exchange. I'm actually here not in the capacity of Sequoia CEO, but as a representative of the governing body for the eHealth Exchange Network, the coordinating committee, and they were not able to be here today. And the other initiative we support is Care Equality, and you heard from Dave earlier. So in terms of the eHealth Exchange, the eHealth Exchange was probably the first public-private health data sharing network that was operating at a national level. It was incubated by ONC back in 2007 and 2008 by really bringing together representatives from the industry, the private sector, and government as ONC supported and incubated the network. Data sharing began in 2009, so this is not an initiative that's in its infancy, but it's actually rather mature, which I think we'll see after 8 years. We're seeing pretty good ramp up of query transactions and push. The eHealth Exchange enables data sharing between the federal agencies for federal agencies using a common standardized approach. It is a federated network. That means there's not a centralized hub. There aren't shared services like the network that Jitten's organization Commonwealth supports the sides at the edge, and there's enough common denominator expectations for the partners to trust one another and share data over the internet. This network was not built around a particular technology or architecture, but rather it was supported really to have a general set of rules of the road and binding obligations through a legal agreement, which I'll discuss, to support a multitude of use cases. So it's really, this list is comprehensive as of today, but the process supporting new use cases. So for example, electronic case reporting is one that we've been in discussions. There are others around how do we leverage some of the workflows with the direct protocols and likewise in supporting the work of HIEs and extending that work. So this is just an example. After 8 years, the network has grown considerably, so there are 160 participants. That just means that there are 160 legal entities who have signed the legal agreement, but it actually represents a very large contingent across the health IT ecosystem. I mentioned the 4 federal agencies, and you can see the other statistics here. And it supports data sharing for almost 110 million individuals in the U.S. We don't, as a federated approach, unlike Jitten, so you have all these statistics, as you know, we rely on self-reporting, right? So we know that one federal agency estimates 2 million exchanges a month. We're estimating, and we'll conduct a survey to get better statistics. And we know that it's tens of millions of push transactions and probably upwards of about 100 million query transactions. So what are the components that make this work? Well, there are actually 5, and I realize my slide only has 3, and then some other things. But one is the legal agreement itself. The Data Use and Reciprocal Support Agreement, or DURSA, is really the binding legal agreement that the participants have bound themselves to as conditions for sharing data with each other. So the first is the legal framework. You can see on the right-hand side of the slide what, it's a multi-party agreement. So there's one agreement, everyone signs the identical agreement, and if there are changes to it, everybody has to agree to those changes and then re-execute that agreement. There's governance. So there is a committee with representatives of participants who govern and oversee the network. And it was important that it be representative governance so that those who are really parties to the exchange are the ones really overseeing the network. The third element are called performance and service specifications. So this is really whatever standards, whatever specifications, whatever use cases that the network participants adopt really fall into this broad category. So they basically adopt whatever technologies and specifications and use cases they want to support. What's interesting is that it was important that there be real transparency in how the network is governed. And so the coordinating committee actually maintains a set of operating policies and procedures which describe exactly how they conduct themselves and fulfill their obligations and authorities in the DRSA. And finally, there are digital credentials, which currently are relying on X.509 digital certificates and a directory of endpoints. So those are really the 5 components of what are, I would say, considerations for a trust framework, the legal agreement being one. But since this is an actual operational network, you can see there are a host of other services that participants have asked in order to make it easier to share data with one another. So it's, of course, having a directory of endpoints, but also onboarding, testing. Also, because it's completely federated, having assurance of system uptime, so doing performance monitoring and security testing and maintaining specs. So this is actually the final slide, and this gives really the tenets of the DRSA, which after 8 years endure without substantive changes. This agreement, surprisingly, and it's flawed, it is a product of 2007 and 8 and 9 thinking, still endures today. And it's because of these, more than principles, these operational tenets that work, and they work at scale, and they persist in many of the other agreements we see. So I'll just highlight 2 or 3. How much time do I have, Lee? Oh, sweet. Okay, I got plenty of time. So governance, of course, is one. Network participants wanted to have very clear governance. How are decisions made? Who makes the decisions? What voice do the participants have? And if you change the rules of the road, having this participatory approach, governance is at the heart of this agreement. And it's still, the structure still works. That the requirements and expectations for compliance are very clear, not open to interpretation, but really that there's uniform understanding across the network, and that there be equality and equitable data sharing. And that means that if you, for instance, if you request data for treatment purposes, well, then you also have to be available to respond to those, so that there's reciprocity. That's where the reciprocal part of the title comes in, and that we'll attribute that to John Luntz in that title, because he was really the one who came up with that concept. There would be clear and uniform expectations for privacy and security, looking to applicable law, but also recognizing there needed to be a higher bar for identity assurance and authentication and access and audit. And that these were things, particularly with cybersecurity rules and changing really risks to our industry, that the network wanted to have the ability to set a higher bar above law, if necessary, to assure and engender trust. These different use cases are enabled, and really almost any use case can be supported by the eHealth Exchange, as long as it's within the parameters of a permitted purpose, which right now was written very narrowly, because we're talking circa 2007 and 8. Would we really trust data sharing for research? Well, now we know that needs to change and broaden to support the many uses in top health and public health and research, and make it more easier to support these. That there was a need and a respect for local autonomy, that there are local policies which, out of necessity and compliance with applicable law, need to be different. And then also incident response. So if there is a security incident, that there's a duty to coordinate with one another, to notify and to coordinate and cooperate. We have never had to formally execute the process, but there have been incidents that we've had to investigate. And fortunately, they did not involve any risk to the actual connections, but it's that coordination at an operational level to assure the integrity of the network. And accountability, finally, is that there has to be consequences for noncompliance. And in this case, you can be found non-compliant, or you can actually have the participation in the network suspended or even terminated. Again, there have been instances where that's been discussed, but it's never been invoked. The interesting thing, and what's been enabled the eHealth Exchange to grow, is the fact that this can all change through a very easy change management process that's measured in a couple weeks. Changing the DRSA is a little bit more complicated, maybe measured in a couple months. The DRSA right now is being amended to broaden the permitted purposes and to take some of the lessons learned to simplify incident response reporting. And also, the coordinating committee is contemplating how to connect to other networks. How can it make it easier to connect to Commonwealth participants, and do so perhaps through the carry quality framework? And that is the benefit of having this actively governed network of its participants really operating, again, in the public interest and being able to adapt over time. So with that, I think that's it.
Good morning. Thank you very much. My name is Aaron Saib. I'm honored to be here speaking to you about the National Association for Trusted Exchange. I think a lot of folks have shared something that's very critical to this nation going forward in establishing a trust framework. I think that a great deal of collaboration occurs between all the folks that have been on this panel so far. I think that there is a lot of interest in supporting consumer-directed exchange, and NATE hopes to play a small part in that and contribute to the success of this organization and contribute to the success of ONC. Dr. Rucker opened with a couple of use cases that were critical, and that's what NATE has really focused on. Can a patient get their data electronically without any special effort on the part of the consumer? I'll share some of the things that we've been doing to try and facilitate that. Also, we have not really cracked how the open API model will work and how it will work for consumers to have access to their data so that they can use it and share it in the ways that they wish through these networks and networks to come in the future. Very briefly about NATE. NATE is in 501c3 incorporated on May 1st, 2013. We are open to all types of stakeholders. NATE has been in existence now for 4 years, but again, like many of the organizations up here, we consider ourselves in our infancy. We try to work with the peers that we have that we share this sandbox with, including our friends at Direct Trust, at eHealth Exchange, Carequality, Commonwealth, Sequoia, so on and so forth. We believe that if this doesn't work for the provider organization, the healthcare delivery system, it's going to be very difficult to make it work for the consumer-facing entities as well. We focus exclusively on consumer-directed exchange. That is exchange that involves the consumer in the transaction. We have always been focused on primarily consumer access, but we were beginning to work in other consumer-based use cases, including consumer-directed exchange and consumer-mediated exchange, working with our friends at the Fire Foundation. When a consumer is in control of their health information, everyone in this crowd, of course, being familiar with this, the consumer has better access and better ability to be part of a directed care plan for themselves. They have a better ability to do comparison shopping and make better decisions about their health and share those decisions with their family. Forward works, backward doesn't. NATE has been around in a prior form. We were known as the Western States Consortium, funded in part by the Office of National Coordinator, State Health Policy Consortium grants. We were formed as the Western States Consortium. Western States Consortium back in 2010 had some activities related to the direct protocol, which essentially, pathway dependence directed where we started our focus on consumer-directed exchange. Today, we operate a consumer trust bundle that's a complement to the Direct Trust bundle used by some organizations to facilitate exchange between providers and consumers. Our membership includes primarily 2 divisions. About half of our members are consumer-controlled apps, and the other half are organizations that are really supportive of NATE's mission, including the Veterans Administration, a number of the states that were part of the Western States Consortium, and other associations like our friends at Commonwealth, HRBA, and others. We think about exchange metrics about consumers as being very important. We see a lot of big numbers from some of the earlier presentations. The only metric that's really important to a consumer is, can I get all of my data in one place when I need it? And if we can count that and measure that for all the consumers that need it the most, those who would benefit the most from the data, we'll have succeeded, and that's why I think that's the most important metric for us to measure going forward with regards to consumer access and consumer engagement. When we were formed from the Western States Consortium, I happened to be the guy that was in DC. We were all state members. We needed to get incorporated, so we got incorporated in the District of Columbia because it wouldn't give any particular state an advantage as far as applicable state law and so forth. NATE was focused primarily on enabling a barrier that our members at the time, the states, were experiencing as covered entities trying to share with non-covered entities. The notion of being able to share as a Medicaid program with Medicaid beneficiaries their health information and their claims information was a big obstacle, and that became our first priority to focus on, and has been our focus since May 1st, 2013. Really, really bad with the turntable here. I asked for 2 turntables and a microphone. I got 1 microphone and 1 turntable. For the past year, NATE has been focusing on a piece of enabling infrastructure that will continue to be a barrier to consumer access. Having many nodes that are electronically connectable through various mechanisms, including a trust framework. I think as Marianne alluded to, a trust framework is only one component. So NATE has been investing in our efforts and focusing our activities in figuring out how do we make it easier for consumers to find out that it's Dr. Suarez who has my data, and that this is the methods that Dr. Suarez supports for me to be able to retrieve that data, either through direct trust or through Commonwealth or through Carequality or through a regional HIE or directly through Kaiser's Epic Everywhere usage. That problem is extremely difficult for folks that are out there trying to do care coordination and navigation, especially for those families that are most in need of that kind of support. So NATE has focused on the NATE Blue Button directory. We've prototyped it. We've actively been contributing and incorporating FHIR-based standards, RESTful APIs, to make that an asset that would be useful to people who want to help consumers more facilely discover how to request their data in an appropriate fashion from the data holders, covered entities. So again, 2 turntables, 1 microphone. I don't know where I need to point. That's not helping. The other component that was alluded to a number of times is how do we determine who and what attributes are true about a given entity, organization, device, person. So identity proofing the individual is an important aspect of that. We need a mechanism, a new mechanism, I believe, that will facilitate the ability to identify all of these attributes for a given transaction and make it easier for relying parties to make disclosure decisions. So again, we've been developing a prototype that allows any type of endorser to participate in a framework that allows registered consumer apps to receive basically a digital signature that they are endorsed by this entity, and a policy engine at the covered entity's location that would allow to determine confidently that they can disclose based on the criteria that have been established. So we are working with the FHIR Foundation. We will be demonstrating this at the Connect-a-thon in September 2017. We hope and believe that it will be a useful part of a broader trust framework that solves multiple use cases. And that's it, with only 1 turntable.
All right. If this was a scalpel, we could kill somebody. Okay, my name is David Kendrick. I'm a physician. I practice internal medicine pediatrics. I'm with a health information exchange in Oklahoma called MyHealth, and I'm here representing the board of the Strategic Health Information Exchange Collaborative. I want to thank ONC for this opportunity to talk about a project we're very excited about. Yes, that's the right direction. Okay, so the Strategic Health Information Exchange Collaborative is a relatively new organization, as you've heard the rest of these folks talk about, but already within the last 2 years since founding has grown to be 54 member organizations across 34 states. What's a little bit unique about the HIEs and CHIC is, of course, is that we provide person-centric charts, the full record, in most cases not just a separate set of CCD files that need to be looked through by the provider, but one summarized unified chart, which is really important. We consider ourselves to be unbiased data trustees that focus on getting data where it needs to go. Almost always we're nonprofits in the community and we're moving data from one place to another. Altogether, we serve more than 195 million patients in these regions you see on the screen, and that's drawn from actual master patient index counts in these organizations. And we've had rapid growth, as you've seen. So before I dive into these words, let me say, you know, these health information exchanges are doing some important things and at the community level. So it's very grassroots. the way these organizations, interoperability happens at the speed of trust, right? And that every person deserves to have their full health record available wherever and whenever it's needed for decisions about their care. And those are two very important principles that cause us to be attentive to and responsive to the communities we grow up in. But that presents a challenge with us in developing a nationwide framework from such community grassroots, right? So what you see on the screen here is a map, and what this shows is, based on those master patient index counts, the percent of the census data, and this is a scale for 2016, that are in a health information exchange participating in the Strategic Health Information Exchange Collaborative. And so you can see that it's pretty good coverage across the country. But I would also add that in addition to resolving identity, organizing the charts, we provide a governance that is those who receive care and services, those who deliver care and services, and those who pay for care and services, which I think touches on the major important perspectives that should be governing the use of sensitive healthcare information. But I will also say that as SHIC members, these health information exchanges have from day one embraced these various health information exchange and interoperability protocols that have been built on top of DIRECT, have been built on top of eHealth Exchange and others, which were the early points of foundation and will continue to be critical modalities for information exchange within the health information exchanges. But I would say that now we've recognized we were running into some limitations with interoperability, and so we stood upon the shoulders of these other giants and said, what can we do that's even more proactive and innovative with interoperability and exchange because of our unique position in these communities and the unique trust that we hold in those communities. So the first thing, we envisioned something called the patient-centered data home, and that is to embody that philosophy I said at the beginning, to make sure that a patient's data, a person's information could all come home to where they live, the area where they live, and be available to them for lots of downstream use cases after the fact. But first we had to have the infrastructure of the patient-centered data home. And the vision for the patient-centered data home is we've been running into troubles with nationwide interoperability because, one, we don't know who exactly we're looking for. If we just slightly change the name, we might not get any hits on the return of any of the searches we put out there. Second, we don't necessarily know when to look. Unless the patient's sitting in front of me saying, I was in the emergency room 6 weeks ago in another state, I don't know to go look there. So we needed a way to know proactively when to look, and then of course where to look. I could look at several hundred nodes, many nodes on these networks that everyone else has described, but I don't exactly know where to look unless somebody is telling me that. So we designed the patient-centered data home to answer these questions primarily. We needed it to be scalable, cost-effective. If you know health information exchanges, you know we're not necessarily flush with cash. To link these at various HIEs together, we want to provide real-time comprehensive patient information. We needed to resolve identity across health information exchanges, and our goal is to do that without needing a universal identifier. And we wanted to preserve this local governance that got us where we are today, because that local trust and governance is critical to our existence. And we wanted to enhance data aggregation for the new use cases and models that are out there, the value-based payment models, the need to support a learning health system and to help generate new knowledge as 21st Century Cures calls for. So here's how it works. I'm sorry this got sort of sized out, but what you see there is a little mostly red area in western Colorado. This is a Quality Health Network run by Dick Thompson here in the audience. And this network this is what we call their home region in western Colorado. And you can see there about 100% of the population there has records in QHN. However, if you take the home region out and look at where else patients live who have received care in QHN's region, what you see is a dramatic need for interoperability between the health information exchanges and among the regions. Many thousands of people whose records are scattered across the country. Now they've got a tourism industry probably much bigger than Oklahoma's, but we also have a map that looks like this, right? So this is Oklahoma's map. It's more than 60% of the U.S. zip codes. There's one person in them that has received care in Oklahoma in the last 5 years. That is astounding. And that is the problem we're trying to address here. So this is the way the patient-centered data home works. First of all, a resident, let's say, of Colorado comes into an Oklahoma emergency room. When that patient registers, their home address is put in the system. And when that home address is put in the system, it's checked and determined that that exists in QHN's region, right there. And so without another thought, the Health Information Exchange in Oklahoma, because of the trust agreements that are in place, pushes that ADT onto Colorado, where QHN receives that alert and decides a few things. First of all, do we recognize this patient? Second of all, what's the consent status of this patient? Can we do anything with this record now that we've received it? And also, they can make follow-up queries back to Oklahoma to receive the records. Now, I happen to know in QHN's case, they actually push to that emergency room doctor the record on the patient so that right then and there, the provider, without having to go seek something, can actually have put into their hands the record to take care of the patient, which is a critically important factor in usability, we think. Finally, the result here is that over time, all of the records on folks who live in a region aggregate in that region. They come back home, so to speak, so that the patient can have that one record, which we believe provides a critical piece of infrastructure needed so that patients can have the possibility in the near future of accessing all their records in one place, not having to go to all the separate hospitals and clinics to get their own personal health record and try and reassemble it themselves. And then, of course, those subsequent transactions can occur through other modalities, direct, e-health exchange, and so on, after that initial ADT. So this is a map that really doesn't say much to you unless I describe it, but we think there are about 20 million patients with records outside of their home region. And that's the burden of interoperability we're trying to cover here with the patient-centered data home. So the implications of this model, it centralizes the record with a complete history. That ADT just doesn't just arrive as an ADT alone, but I can get the context for it. I can get the story around that ADT so I can take the next step. More accurate quality measures are possible, care gap analysis because of the whole record in one place, national patient identity assurance because when that other region sends my region the patient, I resolve that identity and push my identifier back. So there's no need to have one national patient identifier to have accurate information between us. And the possibility, this is the really exciting thing for me, that we could have centralized patient consent management rather than having to go to every place I've ever consented and undo it or change it. I could do it in one place if my records are in the patient-centered data home. And then finally, the cost to do this, well, we've been doing this together for several, as you'll see in a moment, for several, about a year now, I guess, a little over a year. And the cost is pretty manageable to put this in place. So here's the status of the network today. You see we started with 3 pilots, Western, Heartland, and Central. And we've got 3 regions that are now in production, 18 health information exchanges connected, 33.9 million patients covered by those regions, more than 2 million pushed notifications. This is the key. They're pushed. Nobody had to go seek them. They answer who, when, and where, right? And thousands of CCDAs have been moved in response to that. That's sort of, we're early in the phase of doing that. And one of the side effects that's been noted, when HIEs happen to have image exchange, those images also follow the record. So the CT scan, the MRI can move across state boundaries to be used in the care of the patient in the most productive way. And so our expansion is to connect the regions together and then to expand to new regions within the country where you saw other health information exchanges are ready to go. So I would just say that the possibility of this nationwide alerting is great. There are lots of use cases, including HIEs that now are supporting their PDMPs through the opioid crisis. We've provided business continuity. The recent cybersecurity attack, which locked up the data in a hospital, the hospital was able to continue their work because of their health information exchange. QCDR, behavioral health improvement, and social services as well are now being connected through the social determinants programs like the Accountable Health Communities. Finally, with 21st Century Cures, the need for research has been highlighted, and a patient-centered data home is exactly what that needs. Thank you.
So thank you so much to all of our panelists. We're going to go ahead and transition now. So I think we've had our panelists here sitting in the hot lights for long enough. So we thank you so much for joining us today. And just a huge thank you to Dave Cassell representing CareQuality.
Don't let me interrupt.
I promise I won't steal your notes. To Ryan Howells representing the Caring Alliance, to Jen Asani representing Commonwealth, to Walter Suarez representing Digital Bridge, to David Kibbe representing Direct Trust, to Marianne Yeager representing eHealth Exchange, to Aaron Saib representing NATE, and to David Kendrick representing Chic. We know that all of the work you do, that this is obviously just kind of an overview of it, and the amount of different use cases, policy, and technical components that support your work is definitely expansive. So we appreciate you taking the time to share in a very shortened time frame the work that you do. So thank you. And next, we're going to have my boss come up and introduce our personal perspective, Dr. Don.